Jafar Golzarian, and he's a professor of interventional radiology at the University of Minnesota Medical School. He graduated magna cum laude from the University of Brussels School of Medicine in Belgium, where he also completed his radiology residency and a fellowship training in interventional radiology. Dr. Golzarian is the first doctor to perform the prostate artery embolism, and I'm hoping you will explain all that, procedure in the United States, and was one of the first interventional radiologists to perform uterine fibroid embolization. In addition, he has extensive experience in peripheral vascular disease and interventional oncology. Dr. Golzarian is the founder and course director of major meetings in the field of interventional radiology. He has authored more than 170 papers and given more than 400 national and international lectures. Dr. Golzarian and his partner, Dr. Amin Astani, have opened a new outpatient clinic here in Golden Valley called North Star Intervention, North Star Vascular and Interventional. On a more personal note, Dr. Golzarian lives in Plymouth with his wife of 32 years, and he recently became a proud new grandpa. Yeah. So, welcome, Dr. Golzarian.
Thank you, everybody. It's a pleasure to be here, and I know where she got all this information, but great work. It's a pleasure to be here, and you know, we are used to say really very complex words, and I try to just simplify it because I don't know, even we suffer from some of those prostate hyperplasia. You know, we can just say enlarged prostate, right? But you know, that's who we are. Just physicians, they just like to make things complicated, so that you guys are always saying, "Wow, what a smart guy," right? I am an interventional radiologist, and I think before we talk about prostate, just want to clarify what is an interventional radiologist, because in my opinion is one of, if not the best specialties in medicine. We had a survey from Society of Interventional Radiology many years ago asking 1,000 people, random people, what they heard of interventional radiologists. From that 1,000 questionnaire, there were only 2 persons who knew what was interventional radiology. One of them was married to one interventional radiologist, and the other one was a neighbor. So it's amazing how this is not known. But I thought that maybe for a few minutes I talk about it because it's important. So radiologists had always access to X-ray way back. There was no ultrasound, no CT, no MR. But with the X-ray, we could see things and access things much more easier than a surgeon. A surgeon had to open up to see something. We just do an X-ray and we see, well, there is an abscess, or there is something that we can drain or we can treat. And we also had the possibility to inject some dyes in the vessels to see the arteries and the vein. So that made our life easier for us to have a patient on our table, do an angiogram, say, hey, I think I can fix this. Well, I can just go directly and fix that. And so in 1963, at University of Oregon, there was a guy called Charles Dutter. Charlie Dutter, who was seeing a patient who had a problem with his arterial flow to the leg, and the surgeon was going to amputate that leg. He went to the patient and say, hey, to the surgeon, why don't you give me a chance to treat this patient? I may be able to treat him. You are going to amputate him, so what's the big risk? And so the patient agreed. So what he did, he had access to the artery, he put a catheter and then a larger catheter over that and another larger catheter, and that way he dilated this narrowing in the artery, and the flow get back to the leg, and the patient didn't lose his foot. So that was the first year that interventional radiology as a technique that is treating patient was born. And very early on, the other surgeons and specialists said, "Oh, you are radiologists, you are just diagnostic trained, you are not surgeon, you should not fix this patient." So there was a big turf starting there. 33 years later, I was an interventional radiologist, and I was in a meeting and I saw people talk about daughter as surgeon would call him crazy Charlie, because he had this idea that was 30 years ahead of his time. But then after that, balloon angioplasty and stent came, and then suddenly Charlie Daughter was nominated for Nobel Prize, and he is one of the father of interventional radiology. The other one is Dr. Amplatz, here from Minnesota, and as you know, he has invented a lot of things, especially helping kids with heart defect that he treated that. So this is interventional radiology. So when you go to cardiologist who is going to treat the coronary artery because there is a narrowing, it has been started, developed by interventional radiologists. You go to a surgeon who says, "Oh, you have an iliac or aneurysm in your aorta, I need to put a stent graft." That was started and treated by interventional radiology. So a lot of these things, and that's how, when you're asking me why you like this, how did you go to interventional radiology, it's amazing where you can do things without having to cut the patient open. And some of these major surgeries have been now obsolete because of interventional radiology. So one of them is probably this, which is treatment of enlarged prostate with embolization. We'll talk about embolization later on, but men have prostate, women have uterus. They have both the same type of problem, is that the uterus can have fibroid and can bleed. Men can have prostate that can enlarge and compresses the urethra. So as you see here, you have the bladder, you have the prostate, which is the size of a walnut, sitting under the bladder, and the urethra goes through the bladder. And then these are the conduits that come from seminal vesicles that can bring sperm and other things to the prostate and goes help with ejaculation. So when the prostate starts to enlarge, it's going to start to enlarge in the transitional zone, and so it's going to compress the urethra. And by compressing the urethra, men will have difficulty urinating. And what will happen is, first the pressure in the bladder will increase, and the pressure in the bladder tries to push it. At some point, bladder gives up. So one thing that is important is that most of us, by age of 80, we will suffer somehow with enlargement of the prostate, and the majority of those enlargements would be symptomatic, where patient have some urinary symptoms. The cost, of course, in society is extremely high, and these are some of the symptoms that one can have by that compression. Is hesitancy, where they have difficulty initiating urination, and straining to void, weak stream, sometimes prolonged micturition, and feeling that you cannot empty your bladder. You stand up, you go and say, "Oh, I need to go back again." And then retention, urinary retention, where you really need a catheter now because you can't urinate anymore. The other symptoms, we call it irritative symptoms, is not because it irritates the patient, but actually it does really irritate the patient, but it is also because there's inflammation attached to that. Is urgency, patient has to run to the restroom. frequency. Some patients, when they travel from Minneapolis to Chicago, they know all their gas stations, restrooms, because they know that every hour or 2 hours they have to stop and go to the bathroom. Or they are in a plane, and as soon as the restroom gets empty, they jump to go in because they don't know if they can wait. So it's a really difficult situation for some men. Nocturia, waking up at night, is painful for two reasons. One, the patient has to go to urinate and can't sleep. Also, their better half cannot sleep neither, because when they woke up and they make some noises, and their sleep is also disrupted. So those are some of the questionnaire we always ask patients to fill, to be able to see what is the extent of that, and then we ask a quality of life questionnaire to say how bad they feel their life is related to urinary symptoms. So this is important to know. In general, the flow and the pressure are normal. Pressure in the bladder and the flow in the urethra is normal. But when you start to have some obstruction, what happens is that you may live normally, but the pressure in the bladder will increase. When the pressure in the bladder increases, start to pump and compress it more. As you know, any muscle, including the heart, when they work too much, at some point they become thickened, and then they give up. So ideally, we should catch the patient here, but the patient have no symptoms at this point. So a lot of men at the age of 60, they may not have any symptoms, but they already have some enlargement. So that's the ideal situation. But when you get to a situation where you have low flow, that means that usually you have high pressure, and those are the patients that we see most of the time. There are different treatments, but most of the time we say, let's just change your lifestyle. Don't drink caffeine or puffs that are caffeinated. Don't drink after 7 p.m. Try to, you don't like that idea, right? No. Don't drink too much at night. And so change of habits, it answers for a while, but the problem is mechanical. You see, there's a mechanical compression. You can't get rid of the symptoms for 6 months, for a year, for 2 years, but then it will come back. Then there is medication. So you have alpha blocker. For those who are familiar, is like Flomax is the most used drug for this, and that's relaxing the smooth muscle. And then there is also alpha reductase inhibitor. The most famous one is finasteride. That is shrinking the prostate. But this is all temporary, and they have some side effects. So then there's all of this type of surgery, and there are much more that I didn't put here. But I don't want to bother you with the type of surgery. The only thing is just scary for a lot of men is that all of this has to go through urethra. And they usually use a very large tubes that to be able to go and scratch and remove the prosthetic tissues, or like here in HOLEP, they go around the capsule and then they take the prostate tissue out. So a lot of men, when they hear that from the urologist, they run away and they go to internet and then they type, is there any alternative? And then they find prostate artery embolization. And so this is another technique where you see how they come and actually, like the rotor-rooter, they just remove, they actually call it that. And then there is another technique which is Urolift, where they try to kind of open the urethra by compressing the two lobes, but the result of that is not excellent. So there are some complications. The urologists themselves, they know that there is a need for new techniques. And then there is prostate artery embolization, and that's a technique that has been there for many, many years. When we had access to arteries, we can go and close the blood supplies for bleeding and other things. But for this application, prostate artery embolization for enlarged prostate is new. The first study was published from Brazil in 2009, then Portugal in 2011, and we started the first cases in the US in 2012. So it's relatively new, but the technique is not new, the indication is new. So what is embolization? So you always heard about emboli, emboli to the heart, to the lungs, is when there are some clots moving and going and block a vessel. That's a disease. Sometimes you have pulmonary embolism. But embolization is actually a medical procedure where we use particles or beads or coils or metallic spring to go and close the blood supply to an organ, to a tumor, to a cancer, or when the patient is bleeding. We actually find our way through those arteries by injecting a dye. We use a catheter. Catheters are like spaghetti. There's a hole inside, and you can inject some dye and look at the X-ray and find your way. I say interventional radiology, I say to medical students, it's like playing PlayStation every day, because you look at the monitor, you don't open the patient, you don't see, you don't look down, you look at the monitor, and then you try to figure out how to get to a place with tortuosity, difficulty, you change the wire, you change the catheter, and of course, we don't look at it as a game, but it is really fun to do it. So basically, embolization is closing the blood supplies to a tumor, or to a large prostate, or to a fibroid that is bleeding. This is for the women, we don't call it prostate artery embolization, but we call it uterine artery embolization or fibroid embolization. So that technique applies to a lot of indications. So for a lot of us, we'll have neoarthritis. Neoarthritis are related to overuse, but also inflammation, synovial inflammation, some tissues inflammation. We actually now have a technique out of Japan that we are offering now significantly every day now at the North Star, where we go into the arteries, going to that inflammation and close the blood supply, and the pain goes away. As you know, now there's a national crisis on pain medications overuse, especially narcotic. When I was talking to a president of a company called Merit from Salt Lake, I was talking to their president and CEO about this technique and say how it is important for us to be supported to do this technique because it's going to reduce the usage of narcotic. The guy started to almost cry and say, I lost a son to exact same thing, knee pain, drugs, and then overdose. So it's a national crisis. Of course, we have already a lot of problems with insurances that who don't want to pay and then delay things, but this technique is going to help a lot this national crisis against pain medicine. So anyways, go back to type of particles we are using. These are the spheres that we inject inside the arteries to close the blood supply. And for prostate artery embolization, as I said, we go from the groin, artery in the groin, or artery in the wrist, and we get down to, with the catheter, to the prostate artery. Prostate has two lobes here, and you inject these particles, goes to the prostate and close the blood supply here. We do the same thing from the other side, and when you do that, it starts to shrink. Why? Because when there is no blood supply, the prostate is not going to die off, it's going to just be softer. When it's softer, it's going to relieve the pressure into the urethra, and then you start to urinate better. Okay? So how many more minutes do I have just to make sure? 20 minutes with question and answer, right? So I can finish it in 5 minutes or 10 minutes, whatever you guys want. 10. So PAE, how does it work? it's an outpatient procedure. It doesn't need general anesthetic. You come in, you get prepared, we go to the angio suite, we do the procedure. It's usually between an hour to 2 hours procedure. You go back, you stay in a bed for 2 hours, you go home. We ask you not to do too many risky things, not to elevate things, not to run for 2 days, just to heal that artery that we punctured. And after that, you're good to go. It can be done in patients who have general bad conditions. This morning I did that's a patient that was a contraindication for surgery because the patient was on anticoagulation. So we can do that much easier and it's an outpatient procedure. And for men, we are not going through urethra. The techniques that go through urethra are associated with urinary complications like some leak, bleeding complications, and sexual and ejaculation complications. There is a retrograde ejaculation almost in all those procedures, and then there is also sexual dysfunction. So not that it happens to everybody, and these techniques are really good, and there are indications, but I would say when there are less invasive procedures, you should think of that, and then you can always have the choice, if that fails, to go to the more invasive one. So we talked about the case that was done in published 2010 by Carnevale, but like a lot of things, like the uterine fibroid embolization, what we do is by accident. So one physician had a patient that had BPH and had bleeding. We had to go and embolize the prostate artery to treat the bleeding, and then suddenly you realize the patient's symptoms are getting better. That had nothing to do with the reason what he embolized. And that's how we learned how to help patients with fibroids, because we were embolizing that to have this patient have a surgery, so that surgery is not going to bleed as much because the fibroid is very well vascularized. And then some of the patient cancel the surgery, and then surgeons say, what's going on? So I'm doing fine, I don't need your surgery anymore. And that's how the uterine fibroid embolization was born. So what we explain to patients is that in general, 85% of patients have significant improvement of their symptoms. That starts somewhere in the second week and will peak at the third month. So it's a progressive improvement because the shrinkage is going to be progressive. There are really very rare or limited complications. At 5 years, 20% of those patients may have recurrence, but because men don't go to andropause like women go to menopause, there is always hormonal activities and the prostate will grow no matter what technique you do. The TURP or other surgical procedure is the same, unless you remove the whole prostate. And no erection or or ejaculation dysfunction in these patients. So these are complicated. I want to show you just a few things about the North Star. And so some of the questions I always get, as a someone who has been 30 years in academic institution, professors and researcher, why did you change to go to a private practice? And the first question comes in mind, because you want to have more money, because that's usually what people think about private practice. The reality is that to take that big move, you have to get a lot of loan and a lot of risk, and there is always a chance that you fail. Actually, there is more chances that some private practice fails than succeed. Because we wanted to have the state-of-the-art imaging that cost $1.5 million just to install that. So it's clearly, and a smart person look at me and say, at 60 years old, you could go, I was a tenured professor at the university. I was joking, some people were killed to be a tenure, and I gave the tenure away to be doing my own private practice. I could look at 5 to 10 years phase retirement. and be happy, you know. And I am always a happy guy, so it doesn't matter what I do. But what is important here is that I went and really studied that for 2 years, and I am convinced that if you are an honest physician, the best patient care is done in an outpatient basis, not in a hospital setting. Because I don't know, God forbid you guys need to go to the hospital. Where do you park? How often you have to come an hour early to find where you have to go? How many times I see patients in the corridors, where is this building? I say, oh, you are really not there, let me walk you there. And then you get there are hundreds of patients, there are no privacy. You see they come to, I had that experience myself. They come to, you want to have a colonoscopy, you are sitting with 15 other patients. One person come and say, Jafar Golzarian for his colonoscopy. Oh yeah, you look at it and say, yeah, it's me, you know. So I am convinced that for patients that are good candidates for an outpatient procedure, having an outpatient facility where you are the center of attention, you park, you come out, 2 minutes, there are not 10 patients, but 1 patient at a time. They are not concerned about what I am going to do, I'm going to be late, I have to rush this case, there is a fellow who has screwed up or something. So I have a lot of respect for academic practice, and there is really a good reason they are there, but I think a lot of patient care will have to move out of hospitals and will go to private practice or to outpatient facility. And so we started North Star for that reason. And we are actually offering better imaging here than any hospital in the cities, including Mayo Clinic. So our machine is a robotic arm, AI assistant angio suite. You saw that, right? So
very impressive.
yeah, and this is the machine. And the beauty of this is, you see, you can rotate around the patient and generate CT images, while this is not a CT, but can give us a way to see the anatomy, not only in 2Ds when we do the angiogram, but also you do around the CT image where you see the artery relationship with the organ. So it's really amazing. And then also the AI assistance is very important because it can help you to, so you see that's how the image comes, and then they click. With the AI, they remove all the bones, and then what you see in one click, you just see the vessels. And then you can also go and see the vessels distally and more in the organ, and then they give you a roadmap where you can, so you can look at this image again. They are going to remove the vessels, and then you will see they can highlight the artery that goes into the prostate. Actually, this is better. So here they highlight this artery. We know that this artery goes to the prostate. So there are tens of arteries there. And not only that, it can allow you to see that there is an angle here. When you look at this in 2 dimensions, you may not see that angle. So and this is rotating around without injecting, without radiation, and you find the right angle, and then you can just go in and catheterize it directly. You see that it seems to be straight, but it's not straight. There is an angle that you can't see it from here. You just see it from the other image. And so, and then this is how we start to look at this angle here and put the catheter at the origin. Here you can see that this catheter will come at the origin with the wire. If I didn't have that view, it would have been much more difficult. That's why in some other centers the radiation dose is much higher. You have to inject more dye and those type of things. So anyway, I just wanted to show you that, and you can come down to that artery directly and then close the blood supply. Here you see a prostate before embolization, and this is after embolization. You see that some part of it is now darker, so it's going to shrink, and patient go home with some medications, in general, I think this is an amazing procedure for men who have enlarged prostate and have symptoms. I think it's better to figure that out earlier than later, but this treatment is minimal invasive and can help patient to be treated without needing any treatment through the penis, through urethra, and if it fails, which it happens time to time, all the other options are available. So I thank you for your attention. I'm happy to answer any questions.
So, sir, you were talking about insurance and that. Are they at all looking into the possibility of having insurance?
Yeah, for PAE now, we are getting close to have all the insurance finally agreed to that. The American Urologic Association was pushing against this because they are not, the urologists, they don't do this procedure. So,
Thank you very much.
so they wanted to, prevent that. But now finally they approve it, and it's with the insurances, it's a continuous problem. There was this study showing that by asking for pre-approval for a procedure, and they can decide to refuse to pay a medical decision from a doctor to the patient, they save $43 billion a year. So it's a big money problem, and unfortunately we are not powerful enough to fight them. But we just be patient, we write them 10 letters, give them the data, call their CEO, and finally they say, okay, well, do this one. But now I think for PAE, is going to be streamlined because the data is overwhelming.
And what other procedures do you do other than this?
So we do very often fibroid embolization for women with uterus fibroid. Is a benign tumor that can cause bleeding and compression and constipation. So that condition is really very well known, and insurances cover that. We do this for knee pain, for osteoarthritis, as I mentioned. We treat the liver cancer with this. We can get to the tumor and give radiation therapy directly to the tumor, or chemotherapy to the tumor. And there are, visceral aneurysm, when the arteries became enlarged, we can close them, or when there is bleeding. Hemorrhoid bleeding, sometimes this hemorrhoid bleeding can be treated by the same technique. Instead of going to have a surgery that can be sometimes difficult post-op. This is just going through the artery. So anytime you just go through the artery, is some advantage.
So, could this be applied to migraine headaches too?
So migraine headache is a great question. There have been some discussion about that, but it's not yet an approved therapy. But it's not related to one or two vessels. It's much more systematic. So right now there is no treatment with intervention or without.
But do you do cancers, a number of cancers?
We do mostly liver cancer.
Liver cancer?
But then there is another technique we do is ablation, which is microwave, where we put the needle into the tumor in the kidney or the lung or the liver, and we can burn that tumor. That's but for the intravascular delivery of cancer drugs or radiation, right now we are doing only in the liver.
That includes prostate cancer.
Excellent question. Prostate cancer does not respond to just simple embolization. It may be responding to intra-arterial radiation treatment. But what has happened recently is that with this technique, we can shrink the prostate, and then you can get a much better super selective radiation dose to the prostate. So it's an adjunct therapy to radiation to make it smaller so that it can have more efficient dose. Great question.
Is Medicare more likely to pay than private insurance?
Yeah, Medicare is,
Jumped on board.
yeah, Medicare is paying for these, most of these techniques. Because there is a code that we use for embolization, which is organ embolization or vessel embolization. So those codes exist and Medicare approved them. So far they cover it. So I have some gifts and some brochure, and then this is we have an opening on May 1st. So anyone wants to come, you are welcome. Just need to RSVP, and then happy to see you again.